Usually when we talk about a medical diagnosis, there is this expectation of clinical precision. It feels almost like engineering.
Right, like it's very structural.
Exactly. Like if a patient breaks their arm, the x-ray shows that jagged white line, and the orthopedic doctor just points to the film and says, well, there it is. That's the problem.
It is comforting because it's visual. I mean, we inherently trust things we can see, measure with a ruler, and easily categorize as broken or intact.
But then you step into the world of clinical chemistry, and suddenly that x-ray machine is totally useless. We are no longer looking at distinct, solid structures.
No, not at all.
We're looking at a diagnostic landscape that is, well, it's murky. You're looking at millions of molecules, enzymes, and ions interacting in this massive dynamic ecosystem. It is the absolute definition of diagnostic muddy waters.
Yeah, that's a great way to put it.
And as a medical laboratory scientist, you are the one who has to see through that mud. So welcome to this intensive deep dive into the source materials, tailored specifically for you, the listener.
We are glad you're here.
If you are tuning in, you have a very specific mission. You are gearing up for the ASCP MLS exam, and you are staring down the clinical chemistry section.
And that section is no joke. Clinical chemistry makes up a massive 17 to 22% of your entire board exam.
That is a huge chunk.
It really is. And it requires a different type of thinking. You can't just memorize isolated facts. I mean, you have to understand the physiological mechanisms. You have to know the why and the how behind the numbers on the printout.
That is exactly our goal today. We are working from a dense, highly distilled stack of chemistry review notes, packed with clinical charts, hand-drawn mnemonics, and crucial test alerts.
The really high-yield stuff.
Right. And we're assuming you have the foundational knowledge. Like, we aren't going to sit here and define what a cell is or what blood is. We are hunting for those high-yield board associations, the tricky single best answer distinctions, and the underlying logic behind why certain markers go up while others go down.
So we've broken this down into 5 distinct blocks, and after each block, we're going to run through a few rapid patient scenario questions where we give you a brief pause to think, followed by the answer.
And we will end each block with a lightning-fast increased versus decreased quiz. So let's get our hands dirty. We're going to start with the fundamental fuels of the body: carbohydrates, lipids, and the blood that carries them.
Okay, so when we talk about carbohydrates, we're really talking about glucose regulation. Glucose is the primary energy currency for every cell in your body. It is the end product of carbohydrate digestion.
Right.
Because your brain relies almost exclusively on glucose, your body has to maintain serum glucose levels within a very tight, specific window. If it goes too low, you fall into a coma.
Which is obviously bad.
Very bad. But if it goes too high, the blood becomes hyperosmolar, essentially turning into a thick syrup that damages the vasculature.
Which sets up this incredible, constant physiological tug of war. And here is the major concept that you need to cement in your mind. Insulin is the only hormone in the entire human body that lowers blood glucose.
The only one.
Yeah, it is synthesized by the beta cells of the islets of Langerhans in the pancreas. When blood sugar rises, insulin is released, and it acts like a key, unlocking the cellular doors so glucose can move out of the blood and into the tissues to be used for energy. So insulin is this lone defender pulling the rope on one side.
Right. So logically, if insulin is the only hormone pulling the rope to lower glucose, what is pulling on the other side?
A whole lot of things.
Exactly. The body is terrified of hypoglycemia. I mean, it is an immediate threat to life. Therefore, evolution has provided us with a whole team of counter-regulatory hormones that raise blood glucose. Your sources provide a vital mnemonic to remember this team, which is GAGCHET.
GAGCHET, okay.
Yeah, and every single hormone in that acronym causes an increase in serum glucose.
I love a good mnemonic. Let's unpack the GAGCHET team and, more importantly, figure out exactly how they drive glucose up. So
Right.
The first G is glucagon. This is insulin's direct counterpart, produced by the alpha cells of the pancreas. When glucose is low, glucagon is released. It travels to the liver and stimulates glycogenolysis. It basically tells the liver, take that stored glycogen, chop it up into individual glucose molecules, and dump them into the bloodstream.
Yep, perfect. The A in the mnemonic stands for ACTH, adrenocorticotropic hormone, which is secreted by the anterior pituitary. ACTH acts as an insulin antagonist.
So it fights insulin directly.
Exactly. It essentially blocks insulin from doing its job efficiently, keeping glucose in the blood. But ACTH also has a downstream effect. It stimulates the adrenal glands to release our next hormone, which is C for cortisol.
Let's jump to cortisol then. Cortisol is the classic stress hormone from the adrenal cortex. If you are running from a bear, you get energy in your blood. But cortisol doesn't just release stored sugar, it stimulates gluconeogenesis.
That's a great word to break down.
Yeah, I always break it down like this. Gluco means glucose, neo means new, genesis means creation. Cortisol forces the liver to synthesize brand new glucose from non-carbohydrate sources, like breaking down your muscle tissue into amino acids and converting those into sugar.
Exactly. Returning to the mnemonic, the second G is growth hormone, another secretion from the anterior pituitary. Like ACTH, growth hormone is a potent insulin antagonist. It decreases the cellular uptake of glucose.
And that's super testable, right?
Oh, highly testable. If you have a patient with acromegaly, which is a condition caused by a pituitary adenoma secreting massive, unregulated amounts of growth hormone, that patient will almost always present with secondary hyperglycemia because the excess growth hormone is constantly blocking insulin.
Okay, so we have GAGC. Next is H, which is human placental lactogen, or HPL. Obviously, this is produced by the placenta during pregnancy. Its physiological purpose is to make sure the growing fetus gets enough nutrients.
Right, the baby needs sugar.
Yeah, and how does it do that? By making the mother's cells slightly resistant to insulin. This keeps more glucose circulating in the mother's blood, which then crosses the placenta to feed the baby. If the mother's pancreas can't ramp up insulin production to overcome this resistance, what happens? Gestational diabetes.
Spot on. The E is epinephrine, produced by the adrenal medulla. We know it as adrenaline. It drives the fight-or-flight response. To fight or flee, your muscles need immediate energy. So epinephrine rapidly stimulates glycogenolysis in the liver to flood the system with sugar.
And there's a clinical tie-in here for the boards, right?
Yeah, the classic tie-in is a pheochromocytoma. This is a rare tumor of the adrenal medulla that secretes surges of epinephrine. These patients present with racing hearts, high blood pressure, and severe episodic hyperglycemia.
And the final letter T stands for T3 and T4, the thyroid hormones. They govern the basal metabolic rate. When thyroid hormones increase, they stimulate glycogen breakdown and increase the rate of glucose absorption from the intestines.
So that is your gag shit team.
7 hormones actively trying to raise your blood sugar, and only 1 insulin trying to lower it. With odds like 7-1, it makes total sense why diabetes mellitus is such a pervasive disease. The redundancy is entirely stacked on the side of raising glucose.
Yeah, and when that lone defender, insulin, fails, we get diabetes mellitus. Let's look at how we diagnose it. The sources use a great clinical picture, Fido the diabetic dog.
Poor Fido. He's tired all the time. He has polyuria, meaning he's urinating constantly. Because he's losing so much fluid, he has polydipsia, which is increased thirst. He has polyphagia, increased hunger, yet he's experiencing unexplained weight loss. And he has poor wound healing.
Which seems counterintuitive, right? The weight loss despite eating.
Yeah, but because without insulin, the glucose is trapped in the blood. The cells are literally starving in a sea of plenty, so the body starts breaking down its own fat and muscle for energy.
If a patient presents with Fido symptoms, you need the hard laboratory numbers to confirm the diagnosis. Let's lock in the criteria. A normal fasting plasma glucose, the FPG, is less than 100 milligrams per deciliter. Pre-diabetes is between 100 and 125.
Okay, and the diabetes cutoff.
The threshold for diagnosing diabetes mellitus is an FPG greater than or equal to 126 milligrams per deciliter on 2 separate occasions.
Got it. The board exam also loves the oral glucose tolerance test, the OGTT. You give the patient a syrupy drink containing 75 grams of glucose, and you see how their insulin responds over 2 hours.
Right, and what are those numbers?
A normal 2-hour post-load glucose is less than 140. A level between 140 and 199 is impaired tolerance. But if that 2-hour level is greater than or equal to 200 milligrams per deciliter, that is diagnostic for diabetes.
And there's a third way, too, a random casual plasma glucose. If a patient comes in randomly, non-fasting, with a glucose greater than or equal to 200, and they have the classic symptoms of weight loss and polyuria, you can make the diagnosis right there.
Let's talk about the different types of diabetes for a second. Type 1 is an autoimmune destruction of the pancreatic beta cells. The factory is burned down. There is an absolute deficiency of insulin.
Yeah, whereas type 2, which is far more common, is characterized by insulin resistance. The factory is making insulin, but the cellular locks are jammed due to obesity, genetics, or metabolic syndrome.
Which brings up metabolic syndrome. This is a cluster of conditions that dramatically increase the risk of heart disease and type 2 diabetes. We are talking about central obesity, high blood pressure, high triglycerides, low HDL cholesterol, and fasting glucose over 100. It's just an environment of chronic inflammation and resistance.
But how do we monitor these diabetic patients long term? You can't just rely on a fasting glucose because that only tells you what the blood sugar is at that exact moment. The patient could have eaten a whole cake the night before and then fasted for 12 hours to get a good number. Sneaky. To catch that, we use glycosylated hemoglobin, universally known as HbA1c. This is a brilliant test. Glucose in the blood naturally and non-enzymatically attaches itself to the N-terminal valine of the beta chain of hemoglobin.
Right, the glycation process.
Exactly. The higher the blood glucose, the more glucose sticks to the hemoglobin. Because the average lifespan of a red blood cell is 120 days, the HbA1c percentage gives us a highly accurate retrospective window into the patient's average glucose control over the past 2 to 3 months. A normal HbA1c is around 5%. Diabetes is diagnosed at an HbA1c greater than or equal to 6.5%.
Okay, but I have a pushback scenario for you. Let's say you have a patient with sickle cell trait or a severe hemolytic anemia. Their red blood cells are fragile. They aren't living for 120 days. They are bursting and being cleared by the spleen every 30 days.
Oh, that changes everything.
Right. If you run an HbA1c on that patient, the red blood cells haven't been in the circulation long enough to accumulate glucose. The HbA1c is going to be falsely low. It's useless. What do you do? That is a classic board question. When HbA1c is invalid due to altered RBC lifespan, you must switch to measuring fructosamine. Fructosamine measures glucose that is attached to circulating serum proteins, primarily albumin.
Because albumin has a shorter half-life.
Yeah, roughly 20 days. So fructosamine reflects intermediate-term glucose control over just the past 2 to 3 weeks. It is completely unaffected by hemoglobinopathies or hemolytic states.
We also need to monitor for diabetic complications. High glucose is essentially toxic to the tiny blood vessels in the kidneys. To catch early diabetic nephropathy, we look for urinary microalbumin.
Because standard dipsticks don't catch it.
Exactly. Standard urine dipsticks only catch macroproteinuria, but specific microalbumin assays can detect tiny amounts of albumin leaking through the damaged glomerular basement membrane long before overt kidney failure sets in.
Let's also address a vital marker for evaluating endogenous insulin production, which is C-peptide. When the beta cells manufacture insulin, they don't make it in its final active form. They synthesize a large precursor molecule called proinsulin.
And then it gets chopped up.
Right. Before secretion, an enzyme cleaves coinsulin into 2 pieces. You get the active insulin molecule and a biologically inactive fragment called the connecting peptide, or C-peptide.
This means that for every single molecule of insulin your body naturally secretes, it secretes exactly 1 molecule of C-peptide into the blood. They are released in a 1-to-1 ratio.
But why does a medical laboratory scientist care about an inactive fragment?
Because it tells you the origin of the insulin. Imagine a patient arrives at the ER in a severe hypoglycemic coma. You run an insulin level, and it is sky high. Did their body produce a massive surge of insulin from a pancreatic tumor, like an insulinoma, or did they maliciously inject themselves with pharmaceutical insulin?
That's where C-peptide saves the day.
Exactly. You test the C-peptide. Pharmaceutical insulin in a vial does not contain C-peptide. So if the patient injected it, their blood insulin will be massive, but their C-peptide will be near 0 because their own pancreas is suppressed. However, if they have an insulinoma, a tumor churning out natural insulin, both the insulin and the C-peptide levels will be elevated. It's the ultimate metabolic fingerprint.
Before we wrap up carbohydrates, we have to talk about pre-analytical specimen handling because it is the most common way a lab tech ruins a glucose result. Let's say you draw blood into a standard red top tube, meaning there's no anticoagulant, just a clot activator. Get distracted, and that tube sits on the counter at room temperature. What is actually happening inside that tube?
Well, the tube is full of living red and white blood cells. Even though they are outside the body, they're still metabolizing. They are eating the glucose in the serum through the process of glycolysis.
This munching away.
Yeah, and if you leave whole blood unspun, the glucose concentration will falsely decrease by approximately 5 to 7%, roughly 10 milligrams per deciliter every single hour it sits at room temperature.
So if a patient has a true glucose of 100 and you leave the tube on the bench for 3 hours, the analyzer is going to spit out a 70. You falsely diagnosed hypoglycemia. How do we stop the cells from eating the sugar?
We use a gray top tube containing sodium fluoride. Sodium fluoride is a preservative that specifically inhibits the enzyme enolase. Enolase is a critical enzyme in the glycolytic pathway. By blocking analase, you shut down glycolysis completely, preserving the true glucose level for up to 24 hours at room temperature.
It's important to note that fluoride works by binding the magnesium ions that analase requires to function. That is the level of depth you need for the boards.
Okay, let's move into our first set of case questions to apply this. Instead of a dead air pause, let's talk through the logic.
Sounds good.
You're at the bench. A patient's fasting lipid panel shows a total cholesterol of 250, an HDL of 40, and triglycerides of 500. The physician wants the LDL calculated. What do? Take a second to think.
Well, the standard way to calculate LDL is using the Friedewald formula. That formula states that LDL equals total cholesterol minus the sum of HDL plus triglycerides divided by 5. The triglycerides divided by 5 part is an estimate of the cholesterol carried by VLDL, the very low-density lipoproteins.
But look at these numbers. The triglycerides are 500. There is a massive test alert here. You cannot use the Friedewald equation when triglycerides exceed 400 milligrams per deciliter.
Right, because the logic is based on physics and density. When triglycerides are that high, the sample is usually packed with massive chylomicrons and bloated VLDL particles. These particles are huge, they scatter light and create a lipemic, milky serum. When this happens, the mathematical assumption that VLDL equals triglycerides divided by 5 completely breaks down. The math becomes wildly inaccurate.
Exactly. So you would reject the calculation and inform the physician that a direct, homogeneous LDL assay must be performed. Homogeneous assays use specialized detergents and blockers that strip away the VLDL and chylomicrons, allowing the analyzer to directly measure the cholesterol specifically sitting inside the LDL particles, regardless of the triglyceride level.
Since we're in the lipid panel, let's break down those lipoproteins. Lipids like cholesterol and triglycerides are basically fats. They are completely insoluble in water. Blood is mostly water.
Right, oil and water don't mix.
Exactly. If you just dumped pure cholesterol into the blood, it would instantly clump together and form fatal fat emboli. So the body packages these lipids inside water-soluble protein shells called apolipoproteins. These lipid protein vehicles are called lipoproteins, and they're separated by density.
The sources provide some excellent mnemonics here. The largest, least dense lipoproteins are the chylomicrons. Because they are so light, if you leave a lipemic sample in the fridge overnight, the chylomicrons will literally float to the top and form a creamy layer, just like unhomogenized milk.
And what do they carry?
Chylomicrons transport exogenous triglycerides. This is the dietary fat you just ate in a cheeseburger, carrying it from the intestines to the tissues.
Next is VLDL, very low-density lipoprotein. The mnemonic from the notes is that VLDL has the longest initials, and its primary job is to transport endogenous triglycerides, which is the term with the most letters. Endogenous means generated within. VLDL carries the triglycerides synthesized by your own liver out to your adipose tissue for storage.
Then we get to the famous cholesterol carriers, LDL, low-density lipoprotein. The mnemonic is L for lethal. This is the bad cholesterol. LDL's job is to take cholesterol from the liver and deliver it to the peripheral cells.
But there's a catch.
Yeah. The problem is, if there is too much LDL, it drops that cholesterol off inside the walls of your arteries, forming atherosclerotic plaques. High LDL is a primary risk factor for coronary artery disease.
And finally, HDL, high-density lipoprotein. H stands for helpful. HDL is the garbage truck of the lipid world. It performs reverse cholesterol transport. It goes out to the tissues, scoops up the excess unused cholesterol, and hauls it back to the liver to be excreted into the bile. That's why you want a high HDL level. It's actively cleaning your arteries.
Let's run a quick up or down scenario here. A patient is injected with a massive dose of glucagon. What happens to their serum glucose? Up or down?
Think about the Gag-Shet mnemonic. Glucagon stimulates glycogenolysis in the liver, dumping sugar into the blood. So the glucose goes UP.
What about a patient who develops a cortisol-secreting tumor of the adrenal cortex? Up or down?
Cortisol stimulates gluconeogenesis, turning amino acids into sugar. The glucose goes UP. It's part of that Gag-Shet counter-regulatory team.
Perfect. Let's finish up this general chemistry section with Ham and bilirubin, the breakdown of blood. The source note is incredibly brief here. It basically just says, liver dysfunction, everything with bilirubin is increased.
But that is not enough to pass the board exam. We are explicitly pulling in the requested outside board knowledge to map the entire biochemical pathway of heme degradation, because you will absolutely be tested on the differentials of jaundice.
It's a fascinating pathway. An average red blood cell lives for 120 days. When it gets old and rigid, the macrophages in the spleen recognize it and eat it. They break the hemoglobin down into heme and globin. The heme ring is then cracked open and converted into a yellow pigment called unconjugated bilirubin.
Oh, let's focus on the word unconjugated. Unconjugated bilirubin is highly lipid-soluble, meaning it is entirely hydrophobic. It hates water.
Right.
Because it is not water-soluble, it cannot be excreted in the urine. To travel through the watery blood, it has to bind itself tightly to albumin. Albumin acts as a boat, carrying the unconjugated bilirubin to the liver.
Once it reaches the liver, it gets dropped off at the hepatocytes. Inside the liver cells, an enzyme called UDP glucuronal transferase takes that unconjugated bilirubin and attaches glucuronic acid to it. This process is called conjugation. We have now created conjugated bilirubin.
And what's the magic property of conjugated bilirubin? It is hydrophilic. It loves water. Because it is water-soluble, the liver can excrete it into the bile ducts. The bile flows into the small intestine. Once in the gut, normal intestinal bacteria attack the conjugated bilirubin and reduce it into urobilinogen.
Some urobilinogen is reabsorbed, but most of it is oxidized into stercobilin, which is the pigment that gives normal human stool its characteristic brown color.
Understanding this pathway allows you to solve any jaundice case study on the exam. Jaundice is simply the visible yellowing of the skin and sclera when total bilirubin exceeds 2.5 milligrams per deciliter. Let's look at the 3 types of jaundice. First, prehepatic jaundice.
Think of a massive hemolytic anemia, like a mismatched blood transfusion. The red blood cells are exploding in the vasculature.
So the spleen is rapidly breaking down hemoglobin. It produces massive amounts of unconjugated bilirubin. The liver is perfectly healthy, but it's just a factory line that is totally overwhelmed by the volume of raw material.
The boats are full.
Exactly. The albumin boats are full. Because the liver can't process it fast enough, the blood backs up with unconjugated bilirubin. So in prehepatic jaundice, unconjugated bilirubin goes UP, but conjugated bilirubin is normal.
Exactly. Now, consider hepatic jaundice. This is when the liver itself is diseased, like in viral hepatitis or cirrhosis. The hepatocytes are damaged and swollen. They're struggling to conjugate the bilirubin arriving on the albumin boats, so unconjugated bilirubin backs up in the blood.
But that's not all, right?
No, because simultaneously the tissue is inflamed and the bile canaliculi are compressed. So whatever bilirubin the liver does manage to conjugate leaks back out into the bloodstream instead of flowing into the bile. So in hepatic jaundice, both unconjugated and conjugated bilirubin go UP.
And finally, post-hepatic jaundice. The liver is healthy. It's conjugating bilirubin perfectly, but there is a physical roadblock after the liver. The classic example is a gallstone blocking the common bile duct, or pancreatic cancer compressing it. The conjugated bilirubin has nowhere to go.
It can't enter the intestine.
Right, so the pressure built up, and massive amounts of water-soluble conjugated bilirubin regurgitate back into the blood. In post-hepatic jaundice, conjugated bilirubin goes massively UP.
And let's think about the downstream effects of that roadblock. If no conjugated bilirubin is reaching the intestine, the bacteria have nothing to convert into urobilinogen. There is no stercobilin being produced. Therefore, a hallmark clinical sign of a severe post-hepatic obstruction is pale, clay-colored, or chalky white stools.
That's a huge test alert.
Definitely. Furthermore, because conjugated bilirubin is water-soluble, all that excess in the blood gets filtered by the kidneys, resulting in dark, amber-colored urine.
That pathway is vital. In the lab, we typically measure bilirubin using the Chandrasekhar method. This uses a diazo reagent. Conjugated bilirubin, being water-soluble, reacts immediately with the diazo reagent, which is why it's historically called direct bilirubin.
And the unconjugated.
Unconjugated bilirubin, bound to albumin, requires an accelerator, usually caffeine benzoate, to unbind it before it can react with the diazo reagent. Total bilirubin minus direct bilirubin equals indirect or unconjugated bilirubin.
To briefly close out the general chemistry section, we need to touch on 2 related supplemental topics: myoglobin and porphyrins. Porphyrins are the chemical precursors to heme. If an enzyme in the heme synthesis pathway is defective, porphyrins build up, causing a class of diseases called porphyrias, often characterized by severe photosensitivity and port wine-colored urine.
And myoglobin is essentially a single subunit version of hemoglobin found in muscle tissue. It binds oxygen locally for the muscle. Because it is so small, if muscle is damaged like in a myocardial infarction, a heart attack myoglobin leaks into the blood incredibly fast. It is the absolute earliest cardiac marker to rise, shooting up in just 1 to 3 hours.
But here's the catch for the exam. It has terrible specificity. If you run a marathon or fall down the stairs, your skeletal muscles release myoglobin. A high myoglobin tells you muscle is damaged, but it doesn't prove it's the heart.
Which brings us perfectly into the realm of our next major topic: proteins and enzymes. Block 2. We've talked about the fuels, carbohydrates, and lipids. Now we need to discuss the cellular machinery that processes those fuels. Enzymes are the organic catalysts of the body. They accelerate chemical reactions without being consumed in the process.
When we measure enzymes in the clinical lab, we are doing something fundamentally different than when we measure glucose or calcium. We aren't measuring the mass or the physical concentration of the enzyme protein itself. We are measuring its catalytic activity. We are watching how fast the enzyme can chew through a substrate.
But to measure that accurately, the reaction must be happening in a state of zero-order kinetics.
Zero-order kinetics is a concept that trips up a lot of students. It's an issue of rate-limiting factors. Think of enzymes as cashiers at a grocery store and the substrate as the customers waiting in line. If you have 10 cashiers but only 2 customers, the speed at which the customers check out is dependent entirely on the customers.
That is first-order kinetics, right?
Yeah.
The reaction rate is dependent on substrate concentration.
Yeah.
Exactly. But we want to measure the maximum working capacity of the cashiers themselves. We want to know exactly how much enzyme activity is present. To do that, we have to flood the system. We send 10,000 customers into the store. Now, every single cashier is working as fast as they possibly can. The lines are endless.
So the rate at which customers check out is no longer dependent on the number of customers. It is strictly limited by the number of cashiers.
Yes, that is zero-order kinetics. The reaction rate is independent of the substrate concentration because the substrate is in vast excess. The only variable controlling the speed of the reaction is the enzyme activity.
That is a perfect analogy. In the lab, we achieve zero-order kinetics by formulating our reagents with massive concentrations of substrate. So when the board exam asks you about the different enzymes, they're going to group them by the organ tissue they originate from. When cells in an organ die or are inflamed, they rupture and spill their specific enzymes into the blood. Let's start with the liver, the hepatic enzymes.
The major players here are the transaminases, AST aspartate transaminase and ALT alanine transaminase. Both will skyrocket during hepatocellular damage, like acute viral hepatitis. But ALT is much more specific to the liver.
Why is that?
Because AST is found in many tissues, including cardiac and skeletal muscle. Also, AST has both a cytosolic and a mitochondrial form, whereas ALT is primarily localized just in the cytoplasm of the hepatocytes. If ALT is significantly higher than AST, you are almost certainly looking at a liver problem.
Then we have ALP, alkaline phosphatase. ALP is located on cell surfaces, particularly in the biliary tract and in the osteoblasts of bone. So ALP goes up in 2 major scenarios: biliary obstruction, where the backed up bile acids solubilize the ALP off the cell membranes, and periods of intense bone growth or bone disease like Paget's disease.
Because there are different sources, we sometimes separate ALP isoenzymes based on heat stability.
The mnemonic for ALP heat stability is crucial. Placental is most heat stable. Bone is most heat labile. Bone burns up the fastest when you heat the serum to 56 degrees Celsius. If the ALP activity disappears after heating, the source was bone. If it remains, it might be placental or liver.
The last major liver enzyme is GGT, gamma-glutamyl transferase. GGT is highly sensitive for hepatobiliary disorders. It goes up before ALP in biliary obstructions. But its classic board association is alcohol.
Oh yeah, GGT and alcohol.
Yeah, GGT is an inducible enzyme, meaning the liver makes more of it when exposed to certain toxins. GGT levels will predictably go UP following heavy alcohol intake or the use of certain anticonvulsant drugs like phenytoin.
Let's shift organs to the pancreas. The 2 key enzymes here are amylase and lipase. Both of these are digestive enzymes secreted by the pancreas into the gut. If a patient comes into the emergency room with severe, agonizing mid-abdominal pain radiating to their back, you are highly suspicious of acute pancreatitis. The pancreas is literally auto-digesting itself. Which test do you order?
You usually order both, but lipase is the superior marker. Amylase is a smaller molecule, and uniquely, it is the only common plasma enzyme normally cleared by the kidneys and excreted into the urine. It rises very quickly in pancreatitis, usually within 5 to 8 hours, but because the kidneys are constantly filtering it out, it returns to normal within just 2 to 3 days.
And it lacks specificity, right?
Exactly, because it is also produced by the salivary glands. If a child has the mumps, a viral infection of the parotid salivary glands, their serum amylase will be highly elevated, but their pancreas is fine.
Lipase, on the other hand, is much larger. It is not filtered by the kidneys. It rises just as fast as amylase, but it remains elevated in the blood for up to 14 days. More importantly, lipase is far more specific to the pancreatic tissue.
So if a patient has been suffering at home for 4 days before finally coming to the ER, their amylase might have already returned to normal, but their lipase will still be massively elevated, revealing the acute pancreatitis.
Let's transition to muscle and cardiac enzymes. We mentioned myoglobin earlier. Now we need to discuss CK creatine kinase. Total CK goes up in any muscle damage. But to find out which muscle is damaged, we look at its isoenzymes. CK is a dimer, meaning it's built from 2 protein subunits. The body uses M subunits for muscle and BB subunits for brain.
This gives us 3 combinations. CKMM is found predominantly in skeletal muscle. If a patient is crushed in a car accident or has muscular dystrophy, CKMM skyrockets. CKMB is a hybrid, and it is localized primarily in the myocardium, the heart muscle. For a long time, CKMB was the primary test for diagnosing a myocardial infarction.
And the third one?
CKBB is found in the brain tissue. Interestingly, because the B subunit carries a stronger negative charge than the M subunit, if you run an electrophoresis gel, CKBD will migrate the furthest toward the positive anode.
Now, you just mentioned CKMB was historically used for heart attacks. Let's explicitly bring in our supplemental knowledge on cardiac markers. Why don't we rely solely on CKMB anymore?
Because of troponin.
Troponin is the definitive, absolute gold standard cardiac marker. Troponin is a complex of 3 regulatory proteins, troponin T, I, and C, that control the calcium-mediated interaction between actin and myosin in muscle tissue. The cardiac-specific isoforms, CTNI and CTNT, are completely unique to the heart.
The clinical utility of troponin lies in its timing and its unparalleled specificity. If a patient suffers a myocardial infarction, both CKMB and troponin begin to rise in the blood around 3 to 6 hours after the onset of chest pain. CKMB will hit its peak at roughly 24 hours and then rapidly fall back to baseline within 48 to 72 hours.
But troponin stays elevated for a remarkably long time. It can remain detectable in the blood for up to 10 to 14 days after the initial infarction. This is critical.
Because of the late presenters.
Exactly. If a patient had a mild heart attack while alone at home, tried to tough it out, and didn't come to the clinic until 4 days later, their CKMB would be completely normal. You would miss the diagnosis. But their troponin would still be screaming high, proving that myocardial necrosis occurred.
And because troponin is so specific, even a microscopic elevation indicates true cardiac damage. It doesn't elevate from skeletal muscle trauma, unlike CKMB, which can slightly elevate after severe exercise. Troponin is simply the better marker.
Let's pose a quick case scenario here to deliberate. A blood sample is drawn for an ammonia level on an encephalopathic patient. The phlebotomist draws it in a green top heparin tube, sits it on the phlebotomy tray, and finishes their morning rounds. They drop it off at the lab an hour later. What is wrong with this picture? Think about it.
Basically everything. Ammonia is a highly volatile analyte. It is a metabolic byproduct of protein catabolism, primarily cleared by the liver via the urea cycle. When blood is drawn, the red cells contain enzymes that will spontaneously deaminate the amino acids present in the plasma.
So it's making new ammonia.
Yes. The blood cells will continue to generate more ammonia in the tube while it sits on the counter.
Exactly. If the tube is left at room temperature, the ammonia level will falsely increase dramatically. The cardinal rule for drawing an ammonia level is that the tube must be placed immediately on crushed ice, rushed to the laboratory, and spun down in a refrigerated centrifuge within minutes to separate the plasma from the cells.
If you receive a warm ammonia specimen that's an hour old, you must reject it. The result will be falsely UP.
Ammonia is one of the non-protein nitrogens, or NPNs. The other major NPNs are BUN, creatinine, and uric acid. BUN, blood urea nitrogen, is synthesized in the liver from ammonia and excreted by the kidneys.
And creatinine is a waste product of muscle metabolism. It is produced at a very constant rate proportional to an individual's muscle mass. Because it is freely filtered by the glomerulus and not reabsorbed, creatinine is the premier endogenous marker for evaluating renal function and calculating the glomerular filtration rate, or GFR.
When both BUN and creatinine are elevated in the blood, it's called azotemia. We often look at the BUN to creatinine ratio to determine the cause of kidney failure. A normal ratio is roughly 10 to 1 to 20 to 1.
If a patient is severely dehydrated, their kidneys slow down the urine flow to conserve water. Because urea can be passively reabsorbed but creatinine cannot, the BUN shoots way up while the creatinine only rises slightly. This creates a high ratio, greater than 20 to 1, which is characteristic of prerenal azotemia.
Let's move from non-protein nitrogen to the actual proteins. We discussed albumin earlier. It's the massive protein responsible for maintaining oncotic pressure in the vasculature. But the board exam loves testing the various globulins and tumor markers. Let's speed through the clinical utility of the major tumor markers.
A vital caveat first. With very few exceptions, tumor markers are not used to screen the general population or definitively diagnose cancer. They lack the sensitivity and specificity.
So what are they for?
They're primarily used to monitor the efficacy of chemotherapy or to detect cancer recurrence after surgery. If the tumor is surgically removed, the marker should drop to 0. If it starts going UP 6 months later, the cancer has returned.
Exactly. Here are the key associations. AFP, alpha-fetoprotein, elevated in hepatocellular carcinoma, which is liver cancer, and germ cell tumors of the testes.
CA15-3 and CA27.29, both are markers for monitoring breast cancer.
CA19-9, the classic marker for pancreatic and biliary tract cancers.
CA125, highly associated with ovarian cancer.
CEA, carcinoembryonic antigen, the primary marker for monitoring colorectal cancer.
We also have PSA, prostate-specific antigen. This is one of the few markers actually used for screening alongside a digital rectal exam for prostate cancer.
And lastly, thyroglobulin, which is used to monitor for recurrence of differentiated thyroid cancer after the thyroid gland has been completely removed. If the gland is gone, thyroglobulin should be undetectable. If it rises, thyroid tissue is growing somewhere it shouldn't.
That is a phenomenal summary of proteins and enzymes. Time for our rapid up or down quiz.
All right, let's do it.
Amylase levels in a patient with mumps.
Up or down?
Up, because of the salivary gland involvement.
GGT levels after heavy alcohol intake.
It's an inducible enzyme. Let's pivot to a completely different environment. Block 3. Acid base, blood gases, and electrolytes. We've talked about the gears and the machinery. Now we need to look at the precise chemical bath that those enzymes require to function.
Enzymes are incredibly sensitive to their environment. If the pH of the blood shifts even slightly, the three-dimensional structure of the enzyme denatures. It unfolds and it stops working. Normal physiological blood pH is tightly regulated between 7.35 and 7.45.
To understand how the body maintains this, we have to look at the Henderson-Hasselbalch equation. The Henderson-Hasselbalch equation defines the physiological buffer system. It states that the pH of the blood is mathematically determined by the ratio of a base to an acid.
In the human body, the primary buffer system is the bicarbonate and carbonic acid system. For the blood pH to remain at a healthy 7.4, the body must maintain a strict 20-to-1 ratio of bicarbonate, the base, to carbonic acid, the acid.
20 parts base for every 1 part acid. And the beauty of this system is that the body controls both sides of the equation using 2 different organs. The kidneys control the bicarbonate level by excreting or reabsorbing it.
And the lungs control the carbonic acid level. Carbonic acid is directly proportional to the partial pressure of carbon dioxide, or PCO2, dissolved in the blood. If you breathe faster, you blow off CO2, thereby decreasing the acid.
The sources provide an incredibly elegant analogy for interpreting acid-base disorders. Respiratory is a seesaw, metabolic is a swing. Let's break down the mechanics of the respiratory seesaw.
In a respiratory disorder, the primary defect is in the lungs' ability to handle CO2. Imagine the relationship between pH and CO2 as 2 people sitting on a seesaw. They move in opposite directions. Let's say a patient is having a severe panic attack. They are hyperventilating.
They're blowing massive amounts of CO2 out of their lungs.
Right, because CO2 acts as an acid. The acid level in the blood drops. The CO2 side of the seesaw crashes down to the ground. Consequently, the other side of the seesaw, the pH, shoots UP. A high pH is alkalosis. Therefore, hyperventilation causes respiratory alkalosis. CO2 down, pH up. Opposite directions.
Now imagine the reverse. A patient takes an overdose of heroin, an opiate that severely depresses the central respiratory drive. They're barely breathing. Because they aren't exhaling, CO2 backs up and accumulates in the blood. The acid load increases.
So seesaw shifts.
Exactly. The CO2 side of the seesaw rockets upward. The opposite side, the pH, crashes down. A low pH is acidosis. Hypoventilation causes respiratory acidosis. CO2 up, pH down.
That covers the lungs. What about the swing? Metabolic conditions involve the kidneys and their handling of bicarbonate, HCO3. In a swing, both your legs and your body move in the exact same direction. The pH and the bicarbonate move together.
Let's say a patient has uncontrolled type 1 diabetes and falls into diabetic ketoacidosis. The blood is flooded with ketone acids. The bicarbonate in the blood rushes in to neutralize these acids, being consumed in the process.
Because the bicarbonate is being consumed, the HCO3 level drops. The swing moves backward. Following the swing, the pH also drops. Low bicarbonate, low pH, same direction. This is metabolic acidosis.
Conversely, if a patient is suffering from severe prolonged vomiting, they're losing massive amounts of stomach acid, hydrochloric acid. The relative concentration of bicarbonate in the blood rises. The HCO3 level goes UP.
The swing moves forward, so the pH also goes UP. High bicarbonate, high pH, metabolic alkalosis.
The board exam will give you blood gas numbers and ask you to identify the disorder. Just look at the arrows. If pH and CO2 arrows point in opposite directions, it's respiratory. If pH and HCO3 arrows point in the same direction, it's metabolic.
But how does the analyzer actually measure these blood gases? We must bring in our explicit supplemental knowledge on blood gas instrumentation. The blood gas analyzer utilizes 3 distinct electrodes. First, the pH electrode. This is a specialized glass membrane electrode. The glass is formulated so that only hydrogen ions can penetrate it, creating a measurable electrical potential.
Second, the PCO2 electrode, historically called the Severinghaus electrode. This is brilliantly designed. It is essentially a standard pH electrode surrounded by a weak bicarbonate buffer solution, which is enclosed in a Teflon or silicone membrane.
And that membrane is special.
Yeah, this outer membrane is selectively permeable only to CO2 gas. CO2 from the blood diffuses across the Teflon, dissolves into the buffer, alters the pH of the buffer, and that change is read by the internal pH electrode.
Third is the PO2 electrode, known as the Clark electrode. This is an amperometric electrode. It uses a platinum cathode and a silver chloride anode. Oxygen from the blood diffuses across a membrane and is physically reduced at the platinum cathode. This reduction generates a measurable microcurrent of electricity. The more oxygen present, the stronger the current.
But the best instrumentation in the world is useless if the pre-analytical handling is botched. Let's talk through a pre-analytical case. You draw an arterial blood gas on a patient. As you withdraw the needle, a tiny air bubble gets trapped inside the syringe. You don't expel it, you put it on ice and send it to the lab. What happens to the results? Take a moment.
You have to think about the physics of partial pressures. The blood in the syringe is now exposed to a bubble of atmospheric room air. Room air is roughly 21% oxygen and almost 0% carbon dioxide. Arterial blood has significantly less oxygen than room air, but much more CO2.
Because gases always move from high pressure to low pressure to reach equilibrium, oxygen from the air bubble diffuses into the blood, causing a falsely elevated PO2.
Simultaneously, CO2 diffuses out of the blood and into the air bubble, causing a falsely decreased PCO2. Because the CO2 drops, the pH will falsely rise. An air bubble ruins the entire profile.
This brings us to electrolytes, the ions that govern water balance and electrical signaling. We have sodium, the major extracellular cation, potassium, the major intracellular cation, chloride, the major extracellular anion, and total CO2, which primarily represents bicarbonate.
And right away, we have to talk about the #1 pre-analytical nightmare in the chemistry lab: hemolysis.
The sources feature a test alert drawing that you cannot forget. It's a cartoon of a red blood cell crying in agony as it is cut open, spilling its guts. The mnemonic is hemolysis. As the cell bursts, help KLMP the leak. KLMP is spelled KLAMP.
Hemolysis is the mechanical rupture of red blood cells during the blood draw, usually from pulling the syringe plunger too hard or using too small of a needle. When the RBC bursts, it dumps all of its intracellular fluid directly into the serum. Intracellular fluid is chemically vastly different from the extracellular serum we want to test. KLMP tells you exactly which analytes will show massive false increases.
Let's walk through KLMP. K stands for potassium. The concentration of potassium inside a red blood cell is roughly 40 times higher than in the serum. Even slight hemolysis will cause serum potassium to spike dramatically.
L stands for lactate dehydrogenase, LD, an enzyme packed inside RBCs.
A stands for aldolase, an acid phosphatase.
M stands for magnesium, another predominantly intracellular ion.
And P stands for phosphate. If the serum in the tube has a pink or red hue, you cannot report a potassium level. It is completely invalid.
And potassium is incredibly dangerous. High potassium, hyperkalemia can trigger fatal cardiac arrhythmias. This leads to another pre-analytical artifact. Let's say you are drawing a patient's blood. They have rolling veins. You put the tourniquet on as tight as possible. You tell the patient, pump your fist open and close really hard so the vein pops up. They aggressively pump their fist for 2 solid minutes. You finally get the blood. What is the problem? Think about it.
You just induced localized hyperkalemia. Repeatedly pumping the fist forces the skeletal muscles in the forearm to contract intensely. Muscle contraction physically releases potassium and lactic acid directly into the localized venous blood pool trapped by the tourniquet.
When you draw that blood, the potassium and lactic acid will be falsely UP. The systemic blood is fine, but the blood in that specific vein is loaded with waste products.
Once we have valid electrolyte results, we often calculate the anion gap. The anion gap is a mathematical representation of the unmeasured anions in the blood, like sulfates, phosphates, and organic acids. The formula is sodium minus the sum of chloride plus bicarbonate.
A normal gap is roughly 8 to 16. If a patient is in metabolic acidosis, checking the anion gap is the next diagnostic step. If the gap is highly elevated, it means the acidosis is being caused by the addition of abnormal unmeasured acids, think lactic acidosis, diabetic ketoacidosis, or toxic ingestions like methanol or salicylates.
Let's close out this block with iron studies. Iron is highly toxic if it is just floating freely in the blood, so the body manages it meticulously. It is transported through the blood bound to a carrier protein called transferrin. It is stored inside the cells in a massive protein vault called ferritin.
Let's compare two opposite conditions. First, severe iron deficiency anemia. The patient is chronically bleeding. The iron stores are depleted. The ferritin level drops to near zero.
Because the tissues are starving for iron, the liver upregulates production of transferrin. It's pumping out more and more empty buses, desperately trying to catch any stray iron molecule it can find.
So transferrin levels go UP, total iron binding capacity, or TIBC, goes UP, but the actual serum iron is down N. Therefore, the percentage of transferrin saturation drops to the floor.
Now consider hemochromatosis, a genetic disorder of severe iron overload. The body absorbs far too much iron from the diet. The ferritin storage vaults are overflowing, so ferritin goes massively UP. The serum iron is UP.
Because there is so much iron, almost every single transferrin bus is completely full. The percent saturation approaches 100%. To protect itself, the liver down-regulates transferrin production, so the TIBC goes down.
Time for a rapid UP or down quiz to test our acid-base and electrolyte mechanisms.
Hit me.
What happens to blood pH during a massive panic attack with hyperventilation?
It goes UP, you blow off CO2 acid, respiratory alkalosis.
What happens to serum potassium in a severely hemolyzed blood sample?
Massively UP. Remember the KLAMP mnemonic? The intracellular potassium leaks out.
What happens to transferrin levels in a patient with severe iron deficiency anemia?
UP. The liver makes more empty transport buses.
Perfect. We have established the metabolic machinery and the fluid environment. Let's move into special chemistry. Block 4. This is where we look at the complex systems that coordinate all this activity from afar. The endocrine system, toxicology, and therapeutic drug monitoring.
Endocrinology is governed by intricate hierarchy systems called axes. The source snippet distills this hierarchy perfectly. Hypothalamus gives the instruction, which points to the pituitary that relays and amplifies, which points to the end organ that produces the actual hormone.
It is exactly like a corporate ladder. The hypothalamus is the CEO sitting in the boardroom in the brain. It perceives the overall environment and issues broad directives by releasing hormones.
Right below it is the pituitary gland. This is middle management. It receives the CEO's memo and amplifies it, yelling through a megaphone by stimulating hormones into the general circulation.
At the bottom is the end organ, like the thyroid gland, the adrenal cortex, or the gonads. This is the factory worker on the floor. It receives the stimulating hormone and does the actual labor, producing the final active hormone that affects the body.
And this entire corporate structure is governed by negative feedback. When the factory worker produces enough of the final hormone, that hormone circulates back up to the brain. It knocks on the door of middle management and the CEO and says, "We have enough product. Stop yelling." The pituitary and hypothalamus then shut down their stimulating hormones until levels drop again.
Let's apply this corporate ladder to explicitly cover the thyroid testing board requirements. The hypothalamus releases TRH. The pituitary releases TSH, thyroid-stimulating hormone. The thyroid gland produces T4 and T3, which regulate metabolism.
Consider a patient with Hashimoto's disease, an autoimmune destruction of the thyroid gland. This is primary hypothyroidism. The defect is at the primary end organ. The factory worker is dead. Therefore, the blood levels of free T4 are very low.
Because T4 is low, there is no negative feedback reaching the brain. The pituitary middle management panics. It screams louder and louder, trying to stimulate the dead worker. It pumps out massive amounts of TSH. So in primary hypothyroidism, T4 is DWN and TSH is massively UP.
Now, let's look at secondary hypothyroidism. In this scenario, the defect is in the pituitary gland. Perhaps a tumor has destroyed it. Middle management is dead. The thyroid gland factory worker is perfectly healthy, but he is sitting in a dark room with no instructions.
He doesn't produce T4 unless he is told to. Because the pituitary is dead, it produces no TSH. No TSH means the thyroid produces no T4. So in secondary hypothyroidism, both TSH and free T4 are down N.
It all comes down to finding where the feedback loop is broken. The endocrine system also regulates blood pressure via the RAAS pathway, the renin-angiotensin-aldosterone system. If the kidneys sense low blood pressure, they release renin. Renin converts angiotensin into angiotensin I.
As that blood flows through the lungs, ACE, angiotensin-converting enzyme, converts it into angiotensin II. Angiotensin II is an incredibly potent vasoconstrictor. It physically squeezes the blood vessels to raise pressure.
And angiotensin II acts on the adrenal cortex to release aldosterone. Aldosterone's target is the distal tubules of the kidneys. It issues a very specific order. Save the sodium, dump the potassium.
By retaining sodium, water passively follows it back into the blood via osmosis, expanding the blood volume and raising blood pressure. But in exchange for saving that sodium, the kidney must excrete potassium into the urine. So, a patient with hypaldosteronism will present with high sodium, very high blood pressure, and dangerously low potassium.
Well, we mentioned ACE converting angiotensin I to Tologa. Let's explicitly inject the supplemental board fact. ACE levels in the blood are also a key diagnostic marker for sarcoidosis, a systemic inflammatory disease characterized by granulomas, particularly in the lungs. The macrophages within these granulomas actively synthesize and secrete large amounts of ACE.
Moving from internal hormones to external chemicals, let's discuss therapeutic drug monitoring, or TDM. This is pharmacology in the clinical lab. For a drug to be effective, its concentration in the blood must exist within a very narrow Goldilocks zone called the therapeutic window.
The bottom of the window is the MEC, the minimum effective concentration. If the drug drops below this, the infection isn't treated or the seizure isn't stopped.
The top of the window is the MTC, the minimum toxic concentration. If the drug goes above this, the patient suffers toxic side effects like hearing loss or kidney failure.
To ensure the patient stays within this window, the lab measures trough and peak levels. The trough level represents the absolute lowest concentration of the drug in the patient's system. To capture this accurately, the phlebotomist must draw the blood immediately before the next scheduled dose is administered. We use trough levels to ensure the patient is staying above the MEC.
The peak level represents the highest concentration of the drug after it is fully absorbed. It is drawn a set time after the dose is given. We use peak levels to ensure the patient hasn't crossed into the toxic MTC territory.
A key pharmacological concept here is steady state. When a patient starts taking a new pill every 12 hours, the drug level in their blood stair-steps upward. Eventually, it levels off, meaning the amount of drug entering the body exactly equals the amount being cleared by the liver and kidneys. This is the steady state.
As a rule of thumb, it takes approximately 5 to 7 half-lives of a drug for a patient to reach steady state. The lab generally does not draw TDM levels until steady state has been achieved because the levels are still fluctuating before that.
Let's apply toxicology concepts to drugs of abuse and toxins. First, a massive pre-analytical warning. If a police officer brings in a driver for illegal blood ethanol draw, the phlebotomist absolutely must not use a standard alcohol prep pad to clean the patient's arm.
That is a huge red flag. That isopropyl alcohol can contaminate the needle and falsely elevate the blood alcohol reading, instantly ruining the legal chain of custody. You must use a non-alcoholic cleanser like betadine or soap and water.
For acetaminophen toxicity Tylenol overdose, the primary organ at risk is the liver. A massive overdose depletes the liver stores of glutathione, allowing toxic metabolites to destroy the hepatocytes. But you don't just look at a single acetaminophen level.
You plot the serum concentration against the time since ingestion using the Rumac-Matthew nomogram. This chart tells the physician whether the drug level is high enough at that specific time to warrant administering the antidote and acetylcysteine.
When we perform urine drugs of abuse screening, it is a strict two-step process. The first step is the screening test, typically a competitive immunoassay. Immunoassays use antibodies designed to bind to a specific drug class, like opiates or amphetamines. They are fast, automated, and cheap.
However, they're not perfectly specific. Over-the-counter cold medicines can cross-react and cause a false positive for amphetamines. Poppy seeds can cause a false positive for opiates.
Therefore, a positive immunoassay screen is legally considered presumptive. It must be verified by a confirmatory test. The gold standard confirmatory method is gas chromatography mass spectrometry, or GCMS.
The The GC separates the molecules based on their volatility, and the mass spectrometer smashes the molecules into fragments and measures their mass-to-charge ratio. This creates an absolute, undeniable chemical fingerprint of the exact drug molecule present. It completely eliminates false positives.
But drug users know they are being tested, and they attempt to cheat. Adulteration testing is mandatory. If a patient tries to dilute their urine by drinking gallons of water before the test, or literally dipping the cup in the toilet, the lab will catch it.
If the specific gravity of the urine is 1.003 or lower, or if the urine creatinine concentration is less than 20 milligrams per deciliter, the specimen is flagged as diluted or substituted, and the results are rejected.
Let's do a quick, rapid up or down logic check for special chemistry. TSH levels in a patient with primary hyperthyroidism.
The thyroid worker is producing massive amounts of T4. That T4 exerts heavy negative feedback on the brain, so the pituitary middle management shuts down. TSH goes down.
Aldosterone's effect on serum potassium.
Aldosterone tells the kidney to save sodium and dump potassium, so serum potassium goes down.
Excellent. We have arrived at the final section, Block 5. Methods and cross-cutting principles. We've spent an hour discussing the physiology, what the molecules do, and why they matter. Now we must look at the physics of the laboratory. How does the million-dollar analyzer sitting on the bench actually see these microscopic molecules?
The fundamental principle running almost every chemistry analyzer is spectrophotometry. It relies on Beer's law. Beer's law states that the concentration of a substance in a solution is directly proportional to the amount of light absorbed by that solution and inversely proportional to the logarithm of the transmitted light.
In simple terms, more color means more concentration, which means less light makes it through the tube to hit the detector. The analyzer shoots a specific wavelength of light through a cuvette containing the patient's plasma mixed with a reagent.
If there is a lot of glucose, the reaction turns dark pink. Less light passes through. The machine reads the absorbance, plots it on a standard calibration curve, and spits out a concentration number.
What about trace elements, like lead or copper? For those, we use atomic absorption, or AA. Instead of passing light through a liquid, we aspirate the sample into a literal flame.
The heat breaks the chemical bonds, creating a cloud of free, unexcited atoms. We then shoot a specialized light beam through the flame. The free atoms absorb specific wavelengths of light. The amount of light absorbed tells us the concentration of the trace metal.
We mentioned ISE, ion-selective electrodes, earlier for electrolytes. We also have osmometry, which measures the total number of dissolved particles in a solution, regardless of their size, charge, or molecular weight. In the clinical lab, we primarily use freezing point depression osmometers.
The physical rule is that the more particles dissolved in a liquid, the lower its freezing point becomes. The machine supercools the sample, induces freezing, measures the exact temperature at which slush forms, and uses that temperature to calculate the total osmolality. This is vital for detecting toxic ingestions of unmeasured alcohols like ethylene glycol, which massively increase the blood's osmolality.
Let's do a deep dive into serum protein electrophoresis, or SPEP. Electrophoresis separates proteins based on their physical charge and size. You place the serum on an agarose gel, put it in a buffer bath, and apply an electrical current. The source notes provide a silly but effective mnemonic to remember the migration pattern. Albumin is attracted to antianode because of his positive attitude.
It works perfectly because it explains the physics. The buffer solution we use is set to a highly alkaline pH of 8.6. Every protein has an isoelectric point, the pH at which it carries a neutral charge. For almost all plasma proteins, their isoelectric point is lower than 8.6. Therefore, in an 8.6 pH buffer, the proteins act as weak acids and take on a net negative charge.
Because they are negatively charged, when you turn the electricity on, the proteins repel away from the negative cathode and migrate forcefully toward the positive anode. Albumin has the smallest molecular weight of all the major plasma proteins, and it carries the largest number of free negative charges. It is small and is highly motivated.
So albumin sprints out of the starting gate and travels the furthest distance toward the positive anode. Based on this race, the migration order from the positive anode back to the negative cathode is established. Albumin finishes first. It is followed by the alpha-1 globulins, then the alpha-2 globulins, then the beta globulins, and finally, lagging far behind, closest to the negative starting line, are the gamma globulins, which are the antibodies.
The analyzer reads this gel and generates a densitometry graph. You must be able to visually diagnose diseases by looking at the peaks and valleys of this graph. Normally, you see a massive, sharp peak on the far right for albumin, then a small bump for alpha-1, a slightly larger bump for alpha-2, a double bump for beta, and then a wide, gentle, smooth mound at the end for the gamma globulins. That wide mound represents thousands of different healthy antibodies.
But let's look at the pathology patterns. First, active cirrhosis. The liver is failing, so the albumin peak drops. But the most striking feature is what happens between the beta and gamma regions. Normally, there is a distinct valley separating them.
In cirrhosis, that valley completely fills in, creating a solid block called the beta-gamma bridge. Why? Because the diseased liver alters clearance, and the mucosal immune system ramps up, producing large, fast-moving IgA antibodies. IgA naturally migrates exactly between the beta and gamma zones, physically bridging the gap on the gel.
Now imagine a graph where that gentle, wide gamma mound is gone. In its place is a single, massive, incredibly sharp needle-like spike. This is the classic M-spike or monoclonal gammopathy. This is the absolute hallmark of multiple myeloma, a cancer of the plasma cells.
One single malignant clone of a plasma cell is dividing out of control, pumping out millions of identical copies of one specific antibody. Because they are identical, they all have the exact same molecular weight and charge, so they all stack up on the exact same micromillimeter of the gel, creating a sharp spike.
Let's consider nephrotic syndrome. In this condition, the basement membrane of the kidney's glomerulus is severely damaged. The filter is broken. The graph shows the albumin peak dropping drastically because albumin is relatively small and it is all leaking out into the urine.
But fascinatingly, the alpha-2 band spikes massively. Why? Because the alpha-2 band contains alpha-2 macroglobulin. The name says it all, macro. It is physically massive. It is one of the only proteins too large to fit through the damaged kidney filter. Because the blood is losing water and small proteins, the massive alpha-2 macroglobulins are retained and highly concentrated in the serum.
And finally, hypogammaglobulinemia. This is an immunodeficiency state. On the graph, the entire gamma region is virtually flat. The patient simply is not producing antibodies, leaving them incredibly vulnerable to infection.
Before we conclude, we must talk through laboratory math, specifically dilutions. It is a fundamental skill. The exam will give you a scenario where an analyte is so concentrated that the analyzer maxes out and gives a greater than error. You have to manually dilute this sample.
Let's walk through an example out loud. The analyzer says the glucose is greater than 1,000. You decide to make a 1:5 dilution of the patient's serum. What does 1:5 actually mean?
It means 1 part of the patient's serum combined with 4 parts of the diluent, usually saline, to create a total volume of 5 parts.
Exactly. The first number is the sample volume. The second number is the total volume. Let's put mLs to it. If you need 100 milliliters of total diluted solution, you would use 20 milliliters of the patient's serum and 80 milliliters of saline. 20 is to 100 as 1 is to 5.
You run that diluted sample through the analyzer. The machine gives you a result of 300. Is the patient's actual glucose 300? No. Because you diluted the sample by a factor of 5, you must multiply the machine's result by the dilution factor to get the true physiological concentration. 300 times 5 equals a true glucose of 1,500 milligrams per deciliter.
That math is non-negotiable for a lab scientist. And with that, we've touched on every major domain. Let's see one final rapid up or down logic check on the electrophoresis patterns.
Okay, let's hear them.
The albumin band on a gel in a patient with nephrotic syndrome.
Down. The kidney filter is broken and the albumin leaks into the urine.
The alpha-2 band in that exact same nephrotic syndrome patient.
UP. The alpha-2 macroglobulins are physically too large to be filtered, so they are retained and concentrated in the blood.
The gamma band in a patient with multiple myeloma.
Massively UP. That is your sharp, monoclonal M spike representing the cancerous clone of plasma cells.
If you kept pace with that entire discussion, take a breath. You just processed an incredible, dense mountain of high-yield clinical chemistry.
We started this deep dive talking about X-rays. We talked about how clinical chemistry isn't binary. It isn't a clean picture of a broken bone. It is muddy, dynamic, and unbelievably complex. And it is.
But through understanding the physiological mechanisms, why insulin is the lone defender, how a ruptured red blood cell dumps its intracellular potassium, why an air bubble alters gas, partial pressures, you clear the mud, you make the invisible visible.
Here's the final provocative thought I want to leave you with. As you sit down to take this board exam, and more importantly, as you step up to the analyzer on your first night shift, you aren't just processing test cubes or feeding barcoded plastic into a machine.
You are the ultimate metabolic detective.
Exactly. Every single pre-analytical error you catch, like noticing that slight pink hue of a hemolyzed sample and shouting the KLMP mnemonic in your head before you hit verify on a fatally false potassium level that is a misdiagnosis prevented. That is a patient protected from a dangerous, unnecessary medical intervention. When a patient arrives in a coma, the doctor doesn't know if it's drugs, diabetes, or liver failure. You are the one who provides the map.
The laboratory truly is the beating heart of clinical medicine. Without this chemistry, the physicians in the emergency room and the ICU are flying completely blind.
So take this knowledge, use the physiology, understand the why behind the numbers, dominate that 22% of the board exam, and then get out there in the laboratory and go save lives. We will see you on the next deep dive.